So I'll just say something very, very briefly, just to say thank you so much everyone for taking time out of your day to be here. Really, really appreciate it. It's been a really overwhelming response to the talks we've been holding for Climate Week. So thank you especially for coming in person, because I appreciate it's really difficult for people to get the time out of their working day to come and be here in person, but I hope you get to meet a lot of like-minded individuals and get some lunch at some point as well if you would like to. We've had over 140 people signed up throughout the course of the week, and I'm hopeful that all of the talks are attended by people who can hopefully make really positive changes within the NHS and within their role. But I'm particularly grateful to have Prof. Acharya here today and to have Dr. Pfleger here as well, who'll be taking the talk. So I won't talk too much. If you have any questions, my name is Laura, and you know you can get in touch. Otherwise, I'll hand over to the stars of our show today.
Not been described as such, but that's very generous. Thank you very much. I'm Dr. Acharya, Head of School of Medicine, Medical Sciences and Nutrition. I'm absolutely delighted to be here to welcome you all to Climate Week North East. I suspect this audience does not need to be reminded how critically important climate change obviously is to all of us. But I'm particularly impressed by the way Laura has showcased this and made it relevant to each of us as individuals in terms of trying to understand where the priorities are for us as a collective, and having heard the speakers over the course of the week, be empowered to make the decisions about what actions we can take to make a difference. So both NHS Grampian as well as the University of Aberdeen have made commitments in their strategic intent. And it's coincidental, perhaps, that the date for both of those is 2040, although for the NHS there's another date, 2045, to meet some of these ambitious commitments. And I suppose the challenge for everybody when we discuss sustainability and climate change is how, as individuals, we can make a difference. And often we find that we are overwhelmed by the enormity of the task. But I think having heard people who've been thinking about this deeply for a while, and hopefully getting the opportunity to listen to some of our speakers will give us that sense of confidence in terms of not just being able to make the small adjustments that we can as individuals, influence the big adjustments that we can as members to anchor organizations in the Northeast, but also educate the constituency we work with, so patients, the public, students, just the wider society that we inhabit. So I'm very excited about the fact that we've got some excellent speakers, starting with somebody I know I'm delaying by minutes, who are going to share some of their thoughts with us. It's also interesting to note that NHS Grampian has identified some key priority areas, and it can be good to know how we can address some of these. But I think what I'd like you all to think about is how we normalize these conversations so they become part of all group discussions, all management meetings, all strategic plans, so that our adaptations around climate change don't sit on a silo somewhere else. I think that's the biggest challenge for them. So enjoy the week. I hope you get a lot out of the speakers that we're lucky enough to have. So I'd like to thank all of them in advance for taking the time to speak to us. Laura for taking the lead in organising something that I think we should have done ages ago, but better late than never. And a final thank you to all of you for taking time out of your busy diaries to attend this and other talks later this week. So thank you all very much.
Well, good afternoon, everyone. It's my absolute pleasure to open the Medical Schools North East Climate Week 2023. I'm Sharon Pfleger. I work in NHS Highland as a consultant in pharmaceutical public health, and I also co-founded and am the NHS lead for the One Health Breakthrough Partnership that I'll tell you a little bit more about in a little while. So today I want to talk to you about the environmental impact of medicines and how you can actually reduce that impact one prescription at a time. So hopefully by the end of today, I think I need my tech tech guy just to help me move my slides on here. But hopefully by the end of today, you will understand the impact of climate change on health and vice versa. You probably all know a lot about that already, so it'll be a quick recap. We'll then understand the environmental harm caused by carbon emissions and biodiversity loss. And finally, we'll go over to you as a person, as a citizen, and also as a healthcare professional about how you can help the climate challenge that we have. So we're in a code red for humanity. Start with the bad news. We all know that we're trying to keep within this 1.5 degrees of heating. Now more than ever, for years we've been hearing, it's crystal clear we have to raise our ambition and we really have to start to take action right away. But it's us who are doing the damage to our climate. We live in a consumerist society. We want more, we buy more, we do more things. And that includes in healthcare too, and you'll see that later on. And I would also put the challenge out that actually healthcare is becoming more of a consumerist activity in our society. So the impact of climate change on human health. You can see the many different ways that climate change actually impacts on our health, whether it's air pollution, water pollution, vector-borne diseases moving to new areas. 25% at the moment of all global deaths are due to greenhouse gases. I think that's quite a staggering statistic. So whether it's heart attacks, strokes, lung cancer, or respiratory disease, a quarter of what we're treating is caused by climate change. And up to the 20 years, up to 2050, we are likely to see another 250,000 cases of malnutrition, diarrhea, malaria, etc., moving across the world. So quite staggering statistics. And of course, our first tenet in medicine is the Hippocratic Oath, first do no harm. And I put it to you today that that Hippocratic Oath is no longer sustainable, if you pardon the pun, for modern medicine. That actually, yes, we should first do no harm to our patient, but we should also now be thinking of first doing no harm to our planet. Because there is no planet B, and without a healthy planet, we cannot have a healthy population. So let's have a think about, so we thought about climate change and its impact on human health. So let's now think about human health and healthcare's impact on climate change. Well, globally, healthcare contributes 2 gigatons of carbon dioxide to the atmosphere, and that's almost 4.5% of global net emissions. And if we think of the aviation industry, it contributes 6%, so we're really not that far behind. And if we bunged all of healthcare across the world into one country, it would be the 5th largest emitter across the world. So it's just like burning 514 coal-fired power stations 24/7 throughout the year. So I'm here today to talk to you about medicines. And medicines are important in greenhouse gas emissions because they make up about 25% of our total emissions in the NHS. So why do they matter? Well, the prescription of a medicine is the most common thing that we do to our patients now, whether that's to diagnose, to cure, to treat, or to prevent the disease. And in Scotland, we spend just under £2 billion on medicines. In the UK, it's about £20 billion. And our use of medicines is increasing. So over the last 15 years, medicine use has increased by 40%. And that's really down to the fact that we have a growing population, more people to treat, more demand. We have more older people take more medicines. We have technological advances. We now have viral cures for hepatitis C and HIV. Cancer treatment, we now have 4 or 5 lines of therapy for patients. And cancer we now think about as a chronic disease, not a terminal illness in many cases. But we also have a change in our culture, in our society. And I call it the pill for every ill culture, that people now immediately turn to a medicine for a social issue. So something that they could do for themselves, they now think, I'll get a medicine to do that instead. And so we see the amount of waste increasing as well as we see the number of medicines increasing. So Prof mentioned about the strategy coming into NHS Grampian. It's coming into all health boards now. This is the Scotland's Climate Emergency and Sustainability Strategy. And the One Health Breakthrough Partnership that I work with, was instrumental in actually getting medicines as part of this, because so often when we think about emissions in the NHS, we think about the way we heat our buildings, we think about our buildings, we think about the fleet that we use, the cars, but actually our clinical care makes up about 80% of our carbon footprint. So we should be looking at what we're doing to patients and how we're doing it. So in this strategy now, we can see that we are thinking about medicines waste and about environmental pollution from medicines as well. So this pie chart just shows you where our emissions come from in the NHS. And if we look in our Scope 1 emissions, we can see this is anaesthetic gases and inhalers, so about 5% of our total. And over here, 20% is down to all the medicines we use and all the chemicals that we use. So that's the 25%. Now, of course, probably 60 or 70% comes from the development and the procurement. So the manufacture and the bringing it across the sea to where we need those chemicals and medicines. So if we don't actually use that medicine, we get rid of a lot of the carbon footprint. And I always say that the most environmentally sustainable medicine is the one that's not needed, the one that's not used, and the one that's not wasted. So I think part of the problem with carbon emissions and climate change is that it's difficult to get your head round. You see all these figures about tons of carbon dioxide, but you don't actually understand, what does that look like to me? Well, this is something that I've put together to show you what 1 tonne of carbon dioxide emissions actually looks like. So it's the same as setting off 500 carbon dioxide fire extinguishers, or it's the same as you taking a return flight from Paris to New York. So it's a substantial amount of carbon that's going into the atmosphere. So let's start having a look at some of the drugs that do have our carbon emissions. And I know on Wednesday that there's a talk about green theatres, and you'll probably hear a lot more about this. So I'm just going to skim over our anaesthetic inhalational gases today. And remember, with our inhalers, they were about 5% of our emissions. So about 2 to 3% is on our inhalational gases. We have a couple of gases that we use in surgery, sevoflurane and desflurane. And Scotland has become the first country in the world to ban desflurane. And the reason for that, you can see there, is that sevoflurane has a global warming potential of 130 times more than carbon dioxide. But if you look at desflurane, it's coming in at 2,500 times the global warming potential of carbon dioxide itself. So a really environmentally damaging gas. And both of those gases do the same thing. So we now are moving to sevoflurane or to injectable anaesthesia. And we hope that by banning it in Scotland, we'll be saving the amount of emissions that would actually heat 1,700 homes across Scotland every year. So not insignificant. Now, thinking about our inhalers as well, our metered dose inhalers, the ones where you have to press in and squirt the gas out. We prescribe about 7 million inhalers in Scotland every year. MDIs contain hydrofluorocarbons, or HFCs, and these too are very, very powerful greenhouse gases. And you can see there that if you have an MDI, it's like travelling from Aberdeen to Glasgow in the car. But if you prescribe a dry powder inhaler, which doesn't have any gas propellant in it, it's like driving from here to the end of the Langstracht. So what a huge difference there is. So let's look at how hydrofluorocarbons actually compare to carbon dioxide as well. So carbon dioxide there has a global warming potential of 1. You can just about see it on the x-axis there. And if we look at HFA 134, which is in most of our inhalers, it comes in with a global warming potential of 1,300 times more than carbon dioxide. And then if you look at the top one, HFA 227, it's found in Flutiform and Symbicort inhalers that we use quite a lot. Again, you can see its global warming potential there is 3,300 times more. So really making the case for us to switch to dry powder inhalers wherever possible for the patient. This is an interesting table. And I've picked out NHS Grampian and NHS Highland here, but the inhalers, the MDIs that are prescribed every year in Grampian are the same as driving almost 2,000 cars, 15,000 miles a year, the average mileage that we do. And in Highland, it's about 1,000 cars every year. Across Scotland, the MDIs that we prescribe are the same as driving 20,000 cars every year. So if we move to DPIs, that goes to zero, not taking into account, of course, the emissions that are included in manufacturing, the plastic, etc. So quite staggering statistics. So that's carbon emissions. And all we hear about is net zero, net zero, net zero everywhere. And we don't actually hear a lot about the ecological crisis or the loss of biodiversity and pollution. So those two, along with climate change, net zero, actually make up our triple planetary crisis. So I'd like to move on now to what else, what other impact we have in healthcare. And one of the most important concepts to get your head around is the One Health concept. And that is that the health of people, the environment and animals is all absolutely intrinsically linked. We've seen that with the pandemic, haven't we? We had a virus come across from bat to human, and we all suffered the consequences of that, both personally and professionally. 2/3 of the newly emerging diseases are coming from animals. So it's really key that we take a One Health approach to healthcare and to how we live. So I want to take you back, and some of you might still be in the throes of learning all this. It's about 35 years since I've been learning about hepatic impairment, renal impairment, clinical efficacy, etc. And I would ask you, do you learn or did you learn about ecotoxicology or about pharmacoenvironmentology? I have to say that one terribly slowly. It's a long word. I certainly didn't. And basically what that means is the effect of the drug on our environment. So we all think about the patient in front of us before we press that prescribe button, but we don't actually think what happens when the drug gets into the environment. And then there are many routes for pharmaceuticals to get into our environment. It starts off by their production, the effluent, the water coming out of the factory. We're focusing on human pharmaceuticals today, so that's down the right-hand side of this diagram here. And I'll move on to the next one, which shows it a little bit more clearly. So the pharmaceuticals that we end up finding in the environment, about 90% of those come from people taking them. So every time you take a medicine, between 30 and 100% of it, we pee and poo out down our toilets into our wastewater treatment plants. And with that, the metabolites as well. Wastewater treatment plants were never designed to remove tiny, complex chemical molecules. They were designed for biological solids. So it ends up that they don't get completely removed and they get pumped out of the effluent, which is the water that's already been treated, pumped out into our rivers and our oceans. So the water that's coming out has a plethora of pollutants in it, including pharmaceuticals. So about 90% comes from people taking them. About 5% comes from people thinking that the safest thing to do is to flush them down the toilet, whereas it's the worst thing that you could do for a medicine. And about 5% comes from manufacturing in the factories. So let's now have a look at the evidence for pharmaceutical pollution. It's a global issue. This is the latest study that's been done in York University, the biggest study ever, and it looked at 258 rivers across every single continent of the world, and they analysed for 61 pharmaceuticals. And in over a quarter of the rivers where they got results, the concentrations that they found were actually a threat to both environmental and or human health. And the highest concentrations of drugs that they found were our analgesics, antibiotics, and our anticonvulsants. So no surprise really, they're very, very widely used drugs. But we also see in this study that the higher concentrations have been found in areas where our lower to middle income people live. And so the authors hypothesise that there is a socio-economic divide in pharmaceutical pollution. And I'll talk more about that later. So we can see the same in Scotland, whether we're sitting in the Orkney Islands or whether we're looking at the River Almond in Edinburgh, we still see pharmaceuticals coming out in our lochs, our river water and our seawater. Very commonly used drugs there, painkillers, antibiotics and cancer drugs. And this is a very small town right at the top of NHS Highland. And again, the wastewater effluent, and remember, the effluent is the water that's actually been treated already and is being pumped into the environment. This is a small town, and again, most common drugs there. Heart drugs, statins, antibiotics, antidepressants, all being found in our water. So what? We're finding the drugs. What are they doing to our aquatic environment? And I should also mention that one of the wastewater treatment processes, well, all of them actually, the product they actually produce at the end is sludge. So they have the water that they pump out, but they also have this thick sludge. And pharmaceuticals are also found in that. And that gets put as a fertiliser onto our crop fields. So there's evidence that our potatoes, our yams, lettuce, carrots all contain traces of pharmaceuticals as well. So as humans, we'll be getting those traces into our food chain. So thinking about the aquatic environment, the first medicine there is ethinyl estradiol. It's a synthetic hormone used in our contraceptive pills. And when we look at the testes of the male fish, we can see that they are filled with eggs and not sperm. Now, it doesn't take a scientist to tell you that eggs and eggs, it doesn't make good sex. So the population collapses because they're not making baby fish. In the middle one there, fluoxetine, one of our most commonly prescribed antidepressants, was known as Prozac when it was within patent. It delays the tadpole development in frogs. And ciprofloxacin at the bottom, again, a really common antibiotic that we use, actually inhibits the growth of our duckweed. And let's remember when I'm telling you about what this does to the aquatic life and you're thinking, well, so what? It doesn't do anything to humans. Every single one of these is part of our food chain. And when we take something out of our food chain, it has ramifications downwards and upwards as well. So now to move on to some of our non-steroidal drugs, diclofenac, chronic exposure, and that means for a month, for 28 days, in our rainbow trout actually causes degradation in their liver, their kidney and their gills. And you can see at the bottom there, it causes necrosis of the gills. So essentially that leads to fish death because they can't breathe. Staying with diclofenac, but on land this time, vultures in India eat the carcasses of deceased cows that have been treated with diclofenac, and it led to catastrophic population decline. So it's killed off, since I've done this slide, it's now about 99% of vultures, and they are now listed as critically endangered. So it's not just our aquatic life that it's affecting. And again, if we look at ibuprofen in a range of fish here, reproduction, iron regulation, heart abnormalities, enzyme pathways, they're all being disrupted. And paracetamol, one of the most widely prescribed drugs in the world, it's acutely toxic to nearly anything in the aquatic environment. So just to recap on that, the major concerns that we have from pharmaceutical pollution to date are physiological changes, behavioural and reproductive. But one of the ones that we're most worried about is the development and the spread of antimicrobial resistance. And this case study is from a wastewater treatment plant out in India in the Hyderabad region. And around that town, there are about 90 factories that make drugs. And their wastewater all goes through this Patancheru wastewater treatment plant. It was tested for ciprofloxacin, and they found that every day the amount flowing out of that wastewater treatment plant was 44 kilograms of ciprofloxacin. That's enough to treat 90,000 people at the therapeutic dose. Every day it's coming out into their environment. And I talked about the socioeconomics of pollution earlier. About 95% of our drugs now come from the pharmaceutical components of them come from India and China. So we are benefiting from these drugs for our population, but the populations over there are far from benefiting. In fact, they're living in pollution. So we've got to think about the global impact of our prescribing here in Scotland. So AMR is a huge huge global public health issue. It's often called the silent pandemic, but I refer to it as Pandemic Plus. Because if the 6 million deaths in 2 years of the pandemic didn't frighten you, well, by 2050, we think that about 10 million people every year will be dying from the leading cause of death, which will be antimicrobial resistance. The Lancet published the global burden of bacterial AMR in 2019, and back then it was suggesting that even in 2019, 1.2 million people were dying as an absolute result of AMR. And if you think about where you work in the health system, every single part of it uses antimicrobials. So we've really got to be good stewards, because I'm not sure the planning is going on for a new world, a new healthcare where we will not have any antibiotics. And there are so few new antibiotics in the pipeline that it could become the norm that we can't carry out hip operations, we can't carry out caesarean sections because they become too dangerous, because we haven't got the prophylactic antibiotics to cover infection. So pharmaceutical pollution, what don't we know yet? There is emerging evidence about the effect on humans, especially children, pregnant women, older people and immunosuppressed people. But we don't know what daily exposure to these subtherapeutic doses is going to do to human health. We don't know how that cocktail of chemicals, whether it's disinfectants, PFAS, PFOS or pharmaceuticals all mixing together, we don't know how that's going to act. We don't yet have information on all the metabolites, what they're doing to our environment. So there's still a lot of don't knows, but we haven't got time to wait. We have to take a pragmatic approach to this and understand that things that we see in the lab and things that we see in the aquatic environment will probably end up having an effect on humans in years to come. And so in Highland, we developed the One Health Breakthrough Partnership. It's a world first. It is SEPA, Scottish Water, NHS Highland, our Centre for Expertise on Water and our Environmental Research Institute up in the Highlands and Islands working together. Our ultimate vision is for a non-toxic environment, but our mission at the moment is to reduce the environmental impact of prescribing and of healthcare. And we're focusing on pharmaceutical pollution. And we're working right across the pharmaceutical life cycle. So as healthcare professionals, you're probably involved in prescription and consumption here the most. Maybe if you sit around the SMC table, Scottish Medicines Consortium, you might be involved in authorisation. But essentially, the closer you can get to this side, the bigger chance there is that you will have an impact, you will reduce the impact of pharmaceutical pollution. So there's just some examples there of the things that we can do to reduce the pollution effect of our pharmaceuticals. And I'll go over some of those in the presentation later on. We've done a lot of work in the One Health Breakthrough Partnership. I've just got time to go over a little bit today, but if you're interested in our videos, our radio programmes, our reports, our scientific papers, they're all on our website, and I'll give you the link in a page at the end for that. One of the most exciting things that we're doing, and we've been building up to this for 5 years, and we've been working on the research required to get there, is we've now got a new Medical Research Council grant, and we will be doing something called Developing a Framework for Eco-Directed Sustainable Prescribing towards reducing environmental pollution from healthcare practices. So what on earth does that mean? Well, in the NHS, when we prescribe, we think about the patient in front of us, but further on up the line, if we're thinking about our formulary choices or we're thinking about SMC choices, we consider clinical and cost effectiveness. So does it do what it says it does in the trials, and is it value for money for the NHS? And that's how we base our decisions. What this project is going to do is actually to give you prescribers, hopefully, some idea of how good or bad a drug is for the planet, as well as how good or bad it is for our patients. So we're going to have clinical effectiveness, cost effectiveness, and environmental toxicity in there as well. And it'll be the first time in the UK that we do that. I've been talking to probably about 5,000 clinicians across the world over 5 years. And the one question they always ask me at the end is, Sharon, how can you help me prescribe in a greener fashion? So hopefully this will deliver it for our clinicians. So if you work in primary care, I'd love you to take a screenshot of this QR code. This is a survey that is out at the minute. It is live. One of my PhD students is looking at this about blue-green prescribing, because really, instead of prescribing medicines, we should always be thinking about the social prescribing aspect as well. And we hope at the end of this research that we'll have a blue-green prescribing strategy for Scotland. It's asking us what the challenges and barriers are for prescribing socially, but also thinking about that eco-directed prescribing that I talked about previously as well. So the first two objectives for the day were to think about climate change and its impact on health, and health and its impact on climate change. And the last one was actually what you can do about this. So now I'm going to move on to how you can actually reduce your pharmaceutical footprint. And you don't have to be a prescriber. You don't have to prescribe medicines to actually reduce it. You can be working in any arena, because what we want is actually a non-pharmacological intervention. At the end of the day, we want to try and reduce prescribing as much as possible. And I would put it to you that actually prescribing is a failure of our health promotion activities, is a failure of trying to develop resilience in our population. And this shows just where we should be in this healthy river of life. We should be keeping people swimming in the quiet, calm bit upstream, but too often our health education doesn't land, our prevention measures don't land, or they're not fast enough, and we end up with people going over that waterfall into the situation where they need a cure, they need a medicine, they need a medical intervention, and ultimately to death. So think about that river next time you have a patient in front of you, and think about how you could keep that patient at the top of the river. So this is, I find, a staggering statistic. About 50% of the medicines that we prescribe don't get taken as they should, or don't get taken at all. So if we give someone a medicine, we expect it to have a clinical outcome. If it's not being taken, it's not going to have that outcome. So that leads us to more morbidity, more ill health, more people coming back to their GP, more people being admitted to hospital. It's a merry-go-round of health and demand for our services. So if we actually focused on patients, helping patients to take the medicine that we do prescribe, we would stop that merry-go-round. But also, as I said previously, if a medicine is prescribed and it's not taken, there's all that carbon footprint in there, all those carbon emissions that were taken up to actually make the medicine. So it's a total waste. And this is just 3 months waste from the community pharmacies that are in Highland. So we have about, 69, 70. In Grampian, you have double that amount. So you would have double those yellow boxes coming back to you every 3 months. And I find that staggering as well, because we know that the waste that's returned to pharmacies and dispensing GPs is just the tip of the iceberg, that everything else is sitting at home or being flushed down the toilet. And remember, I said that we spend about £2 billion a year on drugs in Scotland. So, you know, if 50% aren't being taken, that's a heck of a lot of money being wasted that we could be using for other things, especially for prevention. This table shows, and it's the size of one of these tables here, shows the medicines from just one deceased patient. So this is a regular occurrence, and in fact I was giving another talk last week and not talking about medicines waste, and 3 people came up to me and said that when they cleared their deceased mum and dad's medicines cupboards out, that they filled plastic bags. So what have we got here? 20 inhalers, we've got about 20 water tablets at the top, packets that have been ordered and ordered again on repeat prescription but never taken. And that in itself, I think for me, shows various issues that we have, whether it's talking to our patients about their medicine, how they're getting on, making sure they know how to take it, our repeat prescribing systems, and just that consumerist society that I've got to stockpile my medicine in case I run out. So what can we begin to do? Well, I'd suggest, first of all, that we actually just think back to the principles of realistic medicine. In it, it talks about risk and benefit, how often do we actually talk about those risks and benefits to our patients? How often as prescribers do we actually understand those ourselves? Do we think about number needed to treat and number needed to harm when we're prescribing? Because quite often, number needed to harm will be much more favourable, much less favourable than number needed to treat. We know there's an awful lot of waste in our clinical care that we provide as well. This report from OECD actually suggests that 20% of the care that we give to patients offers them no clinical value at all. That 1 in 10 of our patients is unnecessarily harmed because of something that we do for them. And that 10% of your hospital budget is used to correct mistakes from clinical care, whether that's side effects from medicines or whether it's something else. And we're now again in this consumerist society where there is quite a bit, 10% they say, of overprescribing, but also overdiagnosis, overtesting, overtreatment. And sometimes for us as clinicians, that's just to make sure, but quite often the evidence base isn't there. We have this study that took place across Scotland, Northern Ireland and the Republic of Ireland. It's called iSympathy, and it was all about polypharmacy. And remember I talked to you about older people at the beginning getting more medicines? By the time one reaches the age of 80, it's quite common to be on 15 to 20 medicines a day. And normally we end up giving one to counteract the side effects of another one that we've given. So it's about having people on the fewest medicines that we can for their condition. And this iSympathy project actually came up with a 7-step approach to polypharmacy. It's got a wonderful website with all of these resources, both for patients and for healthcare professionals. So I'd really urge you to look that up. Something else that you can usefully do is think about BRAN every time you see a patient in front of you. So think about what you're going to do to them, whether it's going to have a benefit or a risk. Is there anything else that you could do? Or what actually if we do nothing? Because we know that a lot of patients only come to us for reassurance that they're not actually looking for something at the end of the day. And we have to be brave enough to understand that and to recognise it and actually say, yeah, let's not do anything. Let's wait. Another one is doped. So you think about the diagnosis. Is that actually correct? Is there anything that's not medicine that you could do? And actually to get that shared decision making going with our patients. And yeah, is the thing that I'm about to do to my patient evidence-based or not? And every time, just try and de-prescribe where you can. So I talked about inhalers earlier. And adherence, we talk about 50% adherence from medicines, but for inhalers it can actually go down to 20%. So obviously we're not going to get the outcomes that we want. Some of the things that work for patients are dose counters on their inhalers, absolutely teaching them the correct technique, counselling them that they should always be taking their preventer inhaler, that it's not their blue inhaler that actually makes the difference. Yes, it makes them feel better when they take it, but actually preventing their asthma or COPD coming back. It's all about taking their preventer. Very shortly, we will see the refreshed respiratory prescribing strategy coming from the Scottish Government. And recently, we have seen the national therapeutic indicators come out. So if you're involved in inhaler prescribing, do take a look at those because there is environmental information in there now. We can also think about our formulations that we have. This is an example from the Green Theatre's work that's going on with the Sustainable Development Centre in Glasgow. And actually paracetamol, if we change from IV to tablet, assuming a 70% switch, we can save almost 40 tonnes of carbon dioxide a year. And that's quite a simple change. And there's also all the plastic that goes with our IV giving sets as well, so we're reducing all that plastic. And it's not just paracetamol. We can think about antibiotics and lots of other drugs that we give around surgery time or in hospital. And I talked about social problems having medical solutions before, and this is a key example. This is the amount of melatonin that's been prescribed. And you can see here, over about 11 years, it's gone from 2 to almost 20% per 1,000 people. So a massive increase. And a lot of that has been in our children, parents going to their doctor because their kids don't sleep. So the social issue around this is that we put our kids in front of iPads to go to sleep now. They have their phones, they have blue light. We know that that upsets our circadian rhythm and we don't sleep. So that's a social issue. It shouldn't need a medical solution. We should be enticing our parents to give their kids a hot bath, a relaxation time before bed, reading a story, giving a milky drink, having some downtime and not having our brains blasted with images on TikTok straight before bed. So what can you do in prescribing? Well, I would think the best advice is actually to think at every single stage of your prescribing before you prescribe. Is a patient actually asking for a medicine? Do they need it? Is there evidence for the medicine that you give? Because there's a quote here from the BMA, Doug Danforth, starting medication is like the bliss of marriage and stopping it is like the agony of divorce. And I think that's a very apt quote because once a patient is on a medicine, they find it very hard to give that medicine up. So let's not start prescribing in the first place. And if we think about prescribing, do we need to do it right now? Can we defer a prescription? If a patient comes in with depression, we know there's as much evidence for an online CBT course, cognitive behavioural therapy, than there is to give them an SSRI antidepressant. So we could send them away to try that for 6 weeks. If they're still feeling depressed, we can then think about prescribing later down the line. Always make sure, though, that we give the minimum dose and the minimum amount of drugs that we have to, and factor in a review so that we can stop that drug very early on in the stage that the patient has it if we need to. So what can you do as a professional? Well, let's think upstream, and I think we can all do this, whether we're in an acute setting or a primary care setting, or whether we're working for a charity. We can promote the things that make a difference to population health. So screening, cancer screening, vaccination, healthy lifestyles, think prevention. Remember, keep them upstream in that river. And then before you give them a medical intervention, is there a social intervention that you can give them? We've talked about optimizing medicines, switching inhalers, switching formulations. But you can educate your patients about waste and how to get rid of things that they don't need afterwards. And you can be an activist, you can advocate amongst your own colleagues, and you can review your practices, ask your formulary group if they can give you a more environmentally sustainable choice for your prescribing in your specialty. Personally, you can think about everything in your life, whether it's your travel, your food, your fashion, your energy, nature. How do you travel to work? Do you cycle? Do you walk? Could you share a car with somebody? Could you have a meat-free Monday in your house if you're a meat-eating family? Keep yourself healthy. Get out in nature. It's been shown that just 5 minutes outside in nature, and you have a lot of lovely nature on this site here itself, just 5 minutes is good for your psychological well-being. So lots of things that we can do personally as well. So I hope that today I've got across the message that climate change is absolutely a health crisis. It is causing changes in our population health, but actually health can and must change that climate crisis. We have the ability to turn this around with our healthcare practices, with our professional practice. If you're interested in anything that I've talked about today, there's lots of CPD here for you. There were QR codes on most of the slides that will be shared afterwards, so you can go directly to some of those documents. So for now, thank you for turning up, probably over your lunchtime to listen to me, and thank you to everyone online as well for participating. And I'd be happy to take any questions that you have.
Thank you so much, Dr. Pfleger, for being here. It's really greatly appreciated, and yeah, fantastic that you've been here to open the very first talk for Climate Week for us. Hopefully Tim, who has been a wizard in the corner, can let us know if there's any questions coming in online. But if there's any questions from the room, please feel free to.
In terms of like some people will dry powder inhalers, is there going to be any guidance maybe coming out like formally for that being like first line rather than MDIs, or?
Yes, that will be contained in the prescribing strategy, but already in the national therapeutic indicators that I mentioned, if you look online, it actually says that there. There are various things to do, like looking at your patients who are using 6 or more short-acting beta agonists a year. So we would prioritise them, get them in for their asthma reviews, change them, switch them over to a dry powder if they're willing to do that. Dry powders are so much easier to use. You don't have that manipulation of the canister and trying to breathe in at the same time. So nearly everybody can use a dry powder inhaler.
Thank you.
You're welcome.
Just when you're talking about the wastewater treatment and the effluents and all, just is there like data as well to show in terms of for the populace that drink tap water, if that also translates to ingesting the drugs in the water, or is that treated out?
Not everywhere. So Scottish Water tells us that our drinking water does not have pharmaceuticals in it, but across the world with different water treatment plants and processes, drinking water does have pharmaceuticals in it in some places. So the data are available on that. Yes.
Question from Teams from Elaine Slattery. How do pharmacies dispose of unused or expired medications?
How do pharmacies, Tim? Okay, so when a patient brings their medicine back to a community pharmacy or to a dispensing GP, it goes into one of those big yellow boxes and it's incinerated. So we can't reuse the medicine, which again is another point for environmental sustainability, because if you give that medicine out and it's not used, it's completely wasted, it's incinerated, and that adds dioxins to the air as well. So best thing is not to give the medicine in the first place. But yeah, that's how you dispose of it in the safest way. Yeah.
Thank you. Excellent talk.
Thank you.
I'm a gastroenterologist, and I've been interested in sustainability for quite a while now. And we have a group called a green endoscopy group. I'm also the lead for sustainability for British Society of Gastroenterology.
Okay.
So we've been doing some work with green endoscopy, because endoscopy is also a very intense, from a carbon point of view, specialty. What is the level of engagement from the industry, from the pharmaceutical industry? Because we have huge barriers when we try and speak to our endoscopy manufacturers, the accessory manufacturers, because there are lots of rules and policies and honestly work. It's not the same as to try and align them with the principles of sustainability is very difficult.
Yep.
So what is the kind of engagement you're getting from the pharmaceutical industry?
So that's an interesting question. So we've been asked for those online who may or may not be able to hear that. What is the level of engagement from the pharmaceutical industry in sustainability? To be honest, I haven't had industry involved in the One Health Breakthrough Partnership. Only last week I spoke to the Ethical Medicines Industry Group. All of our pharmaceutical industries obviously have sustainability as one of their key criteria now for their corporate social responsibility, and they are doing things. I think it's very difficult for the industry. There's a lot of data that we're missing at the moment. So the environmental risk data that we have for medicines only came into being after 2006. So that's really only for our newer medicines. So all of those medicines that I talked to you today about, the industry don't have to do an assessment of risk on those, but they do on new medicines. Even though the industry is doing that assessment, it's not taking into account in the decision-making process for a drug for humans. Stupidly, it is for veterinary medicines, not stupidly, but, ironically. But for humans, we put human health above the environmental risk. So I would throw a challenge straight out to all of us, actually, just like I said at the beginning, there is no planet B. And actually, at some point, we need to start weighing up the balance between the gold standard that we provide to patients and what we do to the planet. So industry does want to engage more. They're involved in my research at the moment. But I would say it's challenging for everyone. It's challenging for industry to talk to the NHS about it, and challenging for the NHS to talk to industry.
There's a whole screen, yeah.
So from Kim Cruttenden, we have, is there additional patient-friendly information coming out with reference to medicines and climate impact?
Okay, thanks for that, Kim. There's lots of patient information in various places. You'll have seen the greeninhaler.org reference that I put up in the inhalers. So there's lots of patient information there as well. I will be developing patient information as part of my research. We have a focus group with patients and the public. It's not all in one place at the moment. So maybe that's something that we need to work better on. Maybe that's something that I'll take away, Kim, from this talk to actually pop some information on my website as well.
I think a question that potentially some of us in the room can answer from Louise McKessick saying that was an interesting and terrifying presentation is the education delivered to medical students.
Mm-hmm.
So that's certainly something that within the University of Aberdeen we're starting to work on delivering for medical students. And I know that in other universities like Edinburgh University and as part of the University of Highlands and Islands with a lot of their healthcare students and now in RGU as well, that's starting to filter into the undergraduate education. I'm not so sure about what we're doing in terms of postgraduate education at the moment, but it is definitely filtering into undergraduate. There's also a lot of really great grants up that's been happening from medical students with resources such as the Planetary Health Report Card, which has evaluated the performance from medical schools in terms of how aware they are of the impact of healthcare on climate change and the education that the university give to medical students. That's a really great resource to anyone who's wanting to bring more education into their establishment. And then from Dermot, we have following on from that question about drinking water, do pharmaceuticals enter the human food chain via fish in contaminated water?
Absolutely, possibly, yes. Via fish, via our soils, as I said about our other ingredients, our carrots, our lettuce, our potatoes. Absolutely.
And then I think last question from Lauria. Desflurane use, if banning is a win-win, why is desflurane still used elsewhere, or are there any trade-offs in effectiveness versus cost?
Yep. So the banning of desflurane, or actually looking at the issue of desflurane, was started in NHS Highland by my colleague Dr Ken Barker some years ago. We banned it in Highland quite a while ago, but actually he's been working with NSS, National Services Scotland, to get it off the buy list in Scotland. So that's what he's done now. NHS England are also looking at it. The Republic of Ireland is looking at it as well. It's now quite common, actually, to be looking at desflurane. If you go to the Healthcare Without Harm website, Healthcare Without Harm's an NGO looking at reducing healthcare's footprint across the world. There's lots of information there as well. So yeah, we're first. We've gone really quickly, but people are following up fast behind.
Any more questions from the room?
In terms of the socio-economic kind of situation you were talking about in seeing the effects in the more deprived areas, how much does that relate to a prescription level in those areas compared to the more affluent or wealthier regions? Is there more prescribing going on for these people living in those areas? Is there a correlation between the two? In
the low to middle income areas, so what I was talking about was the effluent coming out of the factories. Yeah. So there's so much. The wastewater treatment plants are very far behind in technology terms to the ones that we would see in the higher income countries. So actually the effluent from the factories was going in, coming out and providing a therapeutic dose for every single person. There's probably not as much prescribing because there's less access to healthcare in the lower to middle income countries. But what we are seeing is that they're making the drugs for us and they are standing the effects to their more vulnerable populations.
And a question from Jane Gibson. Thank you, it's been very insightful. Nursing is the biggest workforce within the NHS. In what ways are NHS Grampian enabling nurses to disseminate this information, particularly among patients?
Have we got any nurses from NHS Grampian in the room? Sorry to pick on you ladies, but have you heard about sustainability? Do you think about it in your practice? Is anybody telling you? No? No. So we've got, two big no nods coming there. And I think that's in line with what the professor said at the beginning, that actually he's starting to see sustainability, but quite often it's an add-on. Yes.
We're never considering medicine.
Yeah.
So like packaging and different things gets paid for.
Yes. So for those online, we're saying that we're seeing recycling initiatives, thinking about packaging of medicines, etc., but not actually thinking about sustainability per se. When I present, I normally say to people that sustainability, inequalities, things like that, they're always, oh yeah, let's have a think about those as well and what we can do. But actually, they are the golden threads that should be running through our practice. So we shouldn't be looking at a patient without thinking social determinants of their health. What else can we do? Who else can we refer them to? Or thinking about sustainability. Do they need this intervention? How can I treat them in the most sustainable manner? So I know that NHS Grampian is starting to look at this. The professor said that at the recent board meeting that they were considering this. So hopefully you will see lots more coming out. That climate emergency strategy that I showed you at the beginning of the presentation, that now goes along with a policy for boards. So boards have to make a difference for medicines waste, medicines pollution, etc. So I'd say watch this space and actually go out today and tell people what you've heard, or tell them to watch the playback and just get that message out, because it's not all about people bringing it down to you. What's worked so well with Dr. Barker's Des Florane project was coming from the bottom up, that they knew this was an issue and they wanted to do something about it, and they did, and they got in contact with people further up that could help them out. So absolutely, the environmental and sustainability boards that are across every health board now are just looking for clinicians to take the lead on this, because you guys know what needs to be done.
So thank you. I think that's everyone's questions. So just to thank our speaker.
Thank you.
Thank you again so much for being here, to everyone in person and to everyone online. It's incredible that we have people from Orkney, from Grampian, from RGU, there's people from Glasgow, all over the place that have come. So please do speak to people in the room. Please come and introduce yourself to me, because a large part of this week was hopefully to forge better connections and get people to start talking. So please do tell everyone, the next time they prescribe an inhaler, have you heard? Or just get people interested by this stuff. And please do introduce yourself so that we can allow there to be a better correspondence between what happens in the university and the hospital, and also with the sustainability department within NHS Grampian as well. So thank you very much. Please do have some food if you would like, and take it back with you for your very busy days. And yeah, keep in touch throughout the rest of the week.
Thank you.